All right, welcome back to Mice TV from the CAKE PIE Expo 2.0. Our next segment features two world-renowned glaucoma experts, Dr. Sahil Thakur and Professor Indu Pal Kaur. They have arrived in the Mice TV studio fresh from their CAKE session on There's More to Drops in Glaucoma Management. Let's welcome Dr. Thakur and Professor Kaur to the show. Thank you both for being here.
Thank you.
Yeah.
Thank you for having us.
Yeah. So how long have you been in Vietnam? When did you arrive?
So I came on 19th.
Okay.
Just before noon, we just checked in and then quickly went around to have a look at so many things Da Nang had to offer, and it was really beautiful.
Yeah, I think Da Nang is a beautiful place. So I came early as well. I came on the 19th. We had kept a day for Hoi An. It's a beautiful
nice.
city,
Nice.
especially
Yes.
with the lantern festival that happens every night.
Gorgeous.
So beautiful. And then also Da Nang and the Bana Hills with the Golden Bridge. That's really beautiful as well.
Oh, that's great. Yeah, we've talked to a lot of our visiting guests, and most people have gone to see the Golden Hand Bridge.
Yeah, the Bana Hills is definitely the favorite.
Yes.
Very Instagrammable.
All right. Well, I'm going to start out with this question. I'll address this to both of you. We know that glaucoma is a chronic progressive disease that steals sight, and there's challenges in managing that. Let's just talk, what are some of the main challenges that, ophthalmologists do face when it comes to in managing glaucoma patients? I'll ask you first, Professor Kaur.
All right. What I think is that we already have some medicines and some surgeries going on, but now is the time when people are leaving behind the conventional options and looking for the contemporary things, and that is what the entire session on glaucoma drops was about. We had people like Sahil talking about AI and collecting it, and then we had a talk where we talked about MIGS, and then my talk, because I am a formulation scientist, and I actually wanted to talk about, there are issues like compliance. That is a very big challenge because it is being prescribed daily, and several patients are to take at least 3 to 4 drops every day, and that's a big challenge. And then the other challenge is effectiveness of the therapy, because ocular tissue has its own anatomical and other physiochemical as well as physiological constraints to delivery. So the drug molecules which are discovered or developed for applications otherwise may not be actually effective in ocular delivery.
Well, and and I guess this is part of compliance. I've actually seen some studies where the patients are putting their eye drops and they're missing their eye completely.
Yeah.
And they think they're getting them in their eye and they think they're being compliant, but it's just stripped down their cheek.
There is a voluntary non-compliance and there is a non-voluntary non-compliance.
Right.
So this is all about the they want to do it right, but they don't know they are not educated, or they are unable to understand.
Or they could have other conditions that, just don't allow them. Right. Okay, well, moving on, Dr. Thakur, what about you? What do you think are some of the main challenges building on what Professor Kaur said?
Yeah, I think I have a unique perspective because I have seen glaucoma care in two very different setups. So I come from India, in which glaucoma care is purely coincidental. You tend to find a glaucoma patient, you tend to treat them. Singapore has a very different approach with the use of AI. Now we are trying to have an active screening program where we can go into the population and find glaucoma patients. The problem with glaucoma initially starts because it's a silent condition. So the patient doesn't know that they have lost vision till I think there is an advanced glaucoma loss already, and then there is not much that we can do. We either have to go straight to surgery or we have to offer them options like a combined cataract surgery with some sort of a surgical intervention.
Right.
That's why I think it's very important to address glaucoma need of care at multiple time points. That means we have to address the population as a whole by using solutions like AI imaging as well, and then address the second part, which I think every speaker always talks about in their talks, but is still missing at the ground level. That's patient education, compliance, and making sure that they properly put the drops. Because drops at the end of the day are going to be the sheet anchor for glaucoma management till we find a better solution.
Very good. So you brought up artificial intelligence, and I know that there are applications for artificial intelligence, especially in conditions like diabetic retinopathy, used in screening and trying to take the place of over some of these human graders. In glaucoma care, where does AI fit into management?
Yeah, so in glaucoma care, AI comes in as something that the clinicians can use as assistants. Mostly, what happens in glaucoma is it's difficult to diagnose early. That's why we have a lot of advanced imaging modalities like OCT and also OCTA these days. But the problem is interpretation of these modalities is quite difficult because one, availability of the machines is not there in resource poor countries. And the second thing is if the machines are there, there is inadequate training because in the glaucoma imaging space, the equipments come so fast, but the adoption is very slow. Right now in India, I think glaucoma is still managed just by seeing on the slit lamp without any imaging, without any visual fields as well, which is like almost very difficult to believe, but that's the truth. So that's why I think AI comes in as a clinician decision support tool. Moreover, it also offers opportunities for resource poor countries, wherein you have a low acceptability or a low acceptability for advanced technologies, but you have simple things like good imaging devices. So you could just take a simple fundus image, you could take a just simple anterior segment image, and then use AI to predict from those images either the visual fields or the anterior segment OCT parameters. And we are working on both of these issues right now in Singapore.
Okay, well, that's very interesting. I know that you and we've actually talked before about some of these apps that are available. How far off in the future are these from actually maybe being put into at least trials or practice itself?
So yeah, I think the important thing here is we need more of industry involvement in this because this is something which is slow to develop, but once developed, the adoption will be very fast because right now mobile phones have become ubiquitous, and because they are ubiquitous and a few years apart, I think because the QR code scanning, like it has come up so quickly because of COVID. Similarly, I think because of the wider availability of mobile phones and the wider availability of 5G internet as well. Why? Because you need fast image upload capacities to the net because most of the AI algorithms are actually run in the cloud. So these technologies are already there. All we need is some more industry involvement, some more involvement of other partners so that these can come very quickly to the market. A lot of them are being published. A few of them have gone into the FDA approval, but none of them is currently available. And I think the gap there is probably the industry support. I think that's what is lacking right now.
Okay. Okay, well, that's very good. So now we've talked about kind of that approach to management. Let's talk about treatment now. Now, Professor Kaur, during your talk at the expo, you discussed a new implant. Can you tell me a little bit more about that and where we stand?
Yeah, I think we have already some implants in the market. There is a recent approval in 2020 for even the Bimetoprost SR implant, which is an intracameral implant. But then the FDA allowed its use only once. Although people claim that once you are able to control the intraocular pressure for the initial 6 months of treatment, there could be a situation where then you can shift the patient to daily drops. But still a lot remains desirable, like probably it is the polymer use which is not appropriate. So what I suggested here in my talk was a subconjunctival implant, which is much easier to implant, and it is a totally biodegradable system like the Metoprost SR. We in the lecture after me, we had several other implants which are there in the market or in clinical trials, phase 2, phase 2A or phase 1 were also discussed by the speaker next to me. But yes, we are looking to a new era of implants, I think. And subconjunctival, why I support them, again, it was something suggested by the clinicians with whom I held some discussions. We have a larger space in the conjunctiva. The administration is easier, less risky, and the patient also feels comfortable with a subconjunctival implant. So
Now-
maybe we'll soon have a few in the market, few more in the market.
So where is the current status of this? Are we in clinical trials now? Or?
So we have a few products like dexamethasone implant is already there for the past 5-6 years. As I said, bimatoprost SR is there in the market, and a few are in the clinical trials.
Okay. Now, for this implant in particular, is there a certain type of glaucoma that it works to treat, or is it suited for maybe mild, moderate? Can it work in some more severe cases, or is that always just straight to surgery?
So it is majorly open-angle glaucoma, which is
Okay.
being addressed by these implants. And there are certain situations where surgery may be advisable. I'm not the right person to suggest that here. But most of the times, people are trying to manage intraocular pressure rather than doing the surgeries or opening the trabecular pathways, or so all of these drugs they increase the aqueous humor outflow invariably by a variety of pathways. Yeah.
Very good. Well, we are getting towards the end of our interview. I'd like to ask if you'd have any other messages to share with our audience when it comes to glaucoma management. And I know one of the other speakers during your symposium touched on MIGS, and we didn't have time to do it here, but maybe a couple thoughts on MIGS or other treatments in the future?
Yeah, I think I'll take that one. So MIGS is a very important solution that we have in our armamentarium. But the problem with MIGS is the availability. So the maximum glaucoma burden is in Southeast Asia, but in most of the countries, these devices are not available and not approved. What MIGS offers you is a drug-free interval for the patient. So most of the times, MIGS are not a substitute for TRAB. It's very important to understand that. You know, sometimes doctors early in their career, they start doing MIGS for every type of patient. They are not recommended for that. MIGS are only meant for early glaucoma to give the patient some drug-free interval, because drugs are the major things that can affect the ocular surface and then damage the surface of the eye. So MIGS have to be eased into the patient's psyche first, because because a lot of times patients themselves do a Google search before they come to you, okay, and they are going to tell you that this treatment can be the treatment of glaucoma can only happen with eye drops. Why are you suggesting surgery? So that's the part wherein the patient education comes in. We need very good counselors who can explain them why a surgery may be a better alternative for them. And I think that's the problem again. So affordability, availability, and how to pitch the project, that sometimes is lacking in Southeast Asia, and how we pitch it to our patients. A lot of times the patients, if you suggest surgery, they would say no. They would straight away say no. Yeah.
And if they've seen probably a video of eye surgery online, they're even less keen.
One more thing I have to quickly add is that we need a partnership, maybe the physician, the patient, the formulation scientists, and the industry, all of them to come together to look at the opportunities and the options.
Right, and that's what we try to do at all of these congresses, bring everything together.
Absolutely.
Thank you so much, both of you, for joining us.